You know, I feel like we've all been there at some point. You're drying off after a shower, maybe not paying close enough attention, and you push a cotton swab just a fraction of an inch too far into your ear.
Oh, absolutely. Or, maybe you take a really bad, awkward plunge off a diving board.
Yes, and you feel that intense pressure just slap against the side of your head.
Right, and in those moments, you're suddenly acutely aware of this tiny, incredibly fragile membrane.
Exactly. It sits right there between the outside world and your ability to hear it. But have you ever actually stopped to think about what happens when that membrane breaks?
It's terrifying to think about, honestly.
It really is. And more importantly, how on earth does a surgeon go about fixing something so microscopic?
Well, it is a remarkable piece of anatomy. And an even more remarkable surgical challenge. I mean, the margins for error are incredibly small here.
Because we're talking about tiny measurements, right?
Exactly. Mm-hmm. We are talking about operating in a space measured in millimeters, trying to restore an acoustic mechanical system while, navigating around delicate cranial nerves.
Which sounds completely impossible. But today, we are shortcutting your way into understanding that high-stakes world of eardrum repair.
It's a fascinating topic.
We've been looking into the operative protocols, specifically the techniques detailed by surgeons Rebecca Schiffer and Douglas Chen in Chapter 131 of Operative Otolaryngology, Head and Neck Surgery, 3rd edition.
It's a highly technical textbook for sure.
Yeah, but our mission today is to explore the sheer medical ingenuity required to rebuild human anatomy. Okay, let's unpack this. Before we get into the wild ways surgeons actually fix the ear, we need to understand the battlefield. What exactly is broken, and what are the two distinct procedures used to fix it?
Well, we're looking at two structurally related procedures, Myringoplasty and Tympanoplasty.
Right, and the distinction between them fundamentally comes down to the scope of the repair. Correct.
Exactly. So Myringoplasty addresses only the tympanic membrane, basically just the eardrum.
Okay.
If a patient presents with a simple perforation, but the rest of the middle ear anatomy is pristine, then the intervention remains a Myringoplasty.
I was thinking about it like home repair.
Oh, how so?
Well, a Myringoplasty is like patching a hole in your drywall. You spackle it, you paint it, you're done.
That's a great way to put it.
But a Tympanoplasty, that's like patching that hole in the drywall and then having to actually reach inside the wall to fix like rotting wood framing.
Or having to reconnect broken electrical wiring.
Yeah,
because the underlying pathology dictates that deeper dive.
Right.
A Tympanoplasty restores the eardrum, but the surgeon must also elevate what's called the tympanomeatal flap to access the middle ear itself.
To deal with the really bad stuff.
Exactly. They might be dealing with chronic otitis media, or a cholesteatoma, or even a disconnected vesicular chain.
Which are those tiny middle ear bones.
Right. And because of this, the patient profiles for these two procedures often look very different.
So acute trauma patients usually just need that drywall patch.
Usually, yes. And that trauma can come from surprisingly common things. A simple slap on the ear, forceful water compression from falling while water skiing.
Or barotrauma from diving.
Exactly. Or even overly forceful irrigation during routine earwax removal.
Which is absolutely terrifying to consider. You go in to get your earwax flushed out and you leave needing microscopic surgery?
It happens. I mean, the hydraulic pressure generated by a syringe in a narrow canal can easily exceed the strength of the eardrum.
Wow.
But contrast that acute scenario with a Tympanoplasty patient. They typically present with a long-standing history of recurrent infections and chronic drainage, or otorrhea.
So a much more inflamed environment.
Yes. The inflammatory environment in those chronic cases fundamentally alters the surgical approach, but the ultimate goals remain uniform across the board.
Which are what, exactly?
Eliminate the recurrent disease, provide a dry ear, and of course restore the acoustic mechanism to improve hearing.
And there's a massive lifestyle component to this too.
Oh, absolutely. Giving the patient an intact drum means they don't have to live with strict water precautions anymore.
Right. Imagine navigating life never being able to swim or having to meticulously plug your ear every single time you shower.
It's a huge burden.
Getting that closure is a massive quality of life upgrade, but getting there requires some serious preoperative detective work, doesn't it?
It really does. The surgical planning starts long before the patient is in the operating room. The physical exam and patient history serve as a roadmap to the potential disasters hiding behind the perforation.
Right. Like, for instance, if a patient presents with a hole but is also experiencing active vertigo.
That is a hard stop. Operating in the presence of an active vestibulopathy is totally contraindicated.
So you can't touch them if they're dizzy.
Exactly. The balance issues must be completely investigated and managed before anyone takes a scalpel to the ear.
Makes sense. Then there are the physical clues, like the trail sign, which, sounds like we're tracking an animal in the woods.
It kind of does. But in a way, the surgeon is tracking abnormal cellular migration.
Migrating cells.
Yeah. When evaluating a marginal perforation, the surgeon might observe a trail of keratin migrating from the edge.
And that's a red flag.
A huge one. This trail sign indicates that squamous epithelium, basically skin cells, has breached the boundary and started growing in the mucosal space of the middle ear.
Oh, wow. So that completely changes the surgical calculus.
Completely. It signals that this isn't just a simple patching job anymore. There's invasive tissue that must be meticulously removed.
And the audiogram, the hearing test, provides a whole different set of clues, right?
It does. Because a small perforation can actually be associated with perfectly normal hearing.
Wait, really? A hole in your eardrum doesn't always mean hearing loss.
Not necessarily. But if the patient has a really small hole and the audiogram shows a 35 to 40 decibel conductive hearing loss,
then the math doesn't add up.
Exactly. A tiny puncture shouldn't cause that much acoustic disruption. It immediately tells the surgeon that the aceticular chain might be broken or fixed.
So the bones behind the drum are messed up.
Right. And the surgeon has to prep for bone reconstruction before they even make the first cut.
Wow. And during that preparation, they also have to map out the nerves, like the portotympany nerve.
Yes. It runs directly through the middle ear space, passing right behind the eardrum. It is incredibly vulnerable during surgery.
This blew my mind. The nerve runs right through the acoustic machinery of the ear, but it has absolutely nothing to do with hearing.
No, it doesn't.
It controls your sense of taste.
It does. It innervates the anterior 2/3 of the tongue.
That is just wild.
It's one of the more fascinating anatomical quirks. If the surgeon stretches or cuts the chordotympany, the patient wakes up with a persistent metallic taste.
Or they just lose their sense of taste on that side.
Exactly. It's a huge risk.
Speaking of the physical exam, I noticed something in the text that seemed completely counterintuitive to me.
Oh, what was that?
Well, before operating on the problematic ear, the surgeon has to carefully examine the opposite, healthy ear. Wait, why is the surgeon investigating the right ear if the left one is the problem?
What's fascinating here is that the contralateral ear, the opposite ear, acts as a diagnostic mirror.
A mirror for what?
For the patient's systemic eustachian tube function.
Ah, okay, the tube that regulates pressure.
Right. If the non-perforated ear shows deep retraction pockets or significant negative pressure, it reveals a fundamental failure in pressure regulation.
I see.
And studies like the pediatric studies by Collins and colleagues demonstrate that operating on a bad ear, when the good ear shows these signs, yields a much poorer prognosis.
Because the environment is hostile. You are essentially trying to patch a tire that is constantly being deflated by a faulty valve.
That's exactly it. You have to know the environment you're building in.
Right. So the detective work is complete, patient is in the chair. Let's explore the surgical toolkit, starting with simplest repairs before getting to the really heavy-duty stuff.
Well, anesthesia management sets the stage. Minor myringoplasties can be done under local anesthesia using a canal block.
But general anesthesia is preferred.
Heavily favored, yes. The microscopic nature of the work demands absolute, complete immobility from the patient.
Yeah, I would definitely prefer to be fully out while someone is operating millimeters from my brain. So let's look at the simple Myringoplasty for acute ears. Say you just punctured your eardrum with a cotton swab.
Okay.
The surgeon goes in, unfolds the torn edges of the eardrum to pull the skin cells back outside, packs the middle ear with gel foam, and then patches the outside.
That's the basic process, yes.
But the materials used for this patch are wild to me. Stair strips, silk, or literally cigarette paper.
Oh yeah, cigarette paper has a long history in otolaryngology.
Wait, really? Actual cigarette paper?
Yes. It is ultra-thin, lightweight, and provides an ideal rigid bridge. The skin cells of the eardrum need a scaffold to migrate across.
Oh, see.
The paper guides that cellular migration, allowing the drum to autonomously seal the defect.
But what if the hole isn't a fresh tear? Like what if it's a small chronic perforation that has fully healed over its edges, creating a permanent open window?
A simple paper bridge fails in a chronic perforation because the body registers the hole as healed tissue. The edges are mature.
So how do they fix it?
They must disrupt that mature edge to trigger a new healing cascade. They use topical agents like phenol or trichloroacetic acid, meticulously applying it to the rim to chemically burn the edge.
Here's where it gets really interesting, because applying that acid is exactly like scuffing up a punctured bicycle inner tube with sandpaper.
That is a perfect analogy.
Right, if you just stick a rubber patch onto a smooth inner tube, it slides right off. You have to rough up the rubber so it sticks.
The surgeon is doing the exact same thing, freshening the rim to destroy the healed skin layer and expose the underlying capillary bed.
They need that raw bleeding edge so the new graft will actually take and vascularize.
Exactly. Once they establish that raw margin, they need a plug with more structural integrity than paper. Often, they harvest a piece of fat from the patient's earlobe.
And they just shove it in the hole.
Basically, they compress the fat and position it in a dumbbell configuration through the perforation. It expands slightly on both sides, effectively locking itself in place.
That's so clever. And there's also the option of using loose tissue from behind the ear, which is wonderfully referred to as fool's fascia.
Yes, loose areolar tissue. Its pliable nature makes it excellent for smaller plugs.
Okay, but if paper and fat aren't enough, surgeons turn to a mechanically brilliant technique for small to medium holes.
Right, the cartilage inlay technique.
Described by Evie in 1998, I think, also known as the cartilage butterfly graft.
Yes, the mechanical engineering of this approach is completely engrossing. The surgeon harvests a graft from the tragus, that's the little cartilage bump, right in front of your ear canal.
And they leave the dome of it intact for cosmetic reasons, right? So your ear doesn't look weird.
Exactly. Cartilage has inherent rigidity and memory, allowing it to maintain its shape.
But the precision required here is intense. They measure the exact dimensions of the hole and then cut the cartilage graft to be exactly 1 to 2 millimeters larger than the hole.
Correct.
But how do you fit a larger rigid peg into a smaller hole without it just sitting awkwardly on top?
Well, the integration relies on a specialized cut. The surgeon uses a curved blade to carve a 2 millimeter deep trough around the entire perimeter of the graft.
Oh, creating like a dual flange structure?
Exactly. It resembles a microscopic groove wheel, or a butterfly with wings.
So they take this custom carved butterfly, navigate it down the ear canal, and physically wedge it into the perforation until it snaps into place, like a button.
Yes. One flange deploys inside the middle ear, and the other stays on the outside. The remnants of the patient's eardrum are locked securely inside that tiny groove.
That is amazing. And the benefits are massive, right? Less pain because they don't have to slice open the ear canal.
And immediate hearing improvement because they don't have to pack the canal tightly with gel foam. The friction fit mechanics hold it all together.
But reading about this friction fit, I couldn't help but wonder about the margin of error. If it's just wedged in there without stitches, what happens if the surgeon cuts the cartilage just a fraction of a millimeter too small?
This raises an important question, because the sizing of the inlay is arguably the most critical variable in the entire procedure.
I'd imagine so.
If a graft is carved too large, it stubbornly refuses to seat into the perforation. You have to take it out and resize it.
And if it's too small?
That presents a severe logistical problem. It lacks the surface area to engage the eardrum remnants and will simply fall through the perforation,
Oh no.
dropping freely into the middle ear space. The surgeon is then forced to blindly retrieve the stray cartilage from among the delicate ossicles.
Risking huge acoustic damage, which perfectly transitions us into the most complex scenarios.
The heavy-duty fixes.
Right. What happens when the hole is massive, like a near total perforation? Or if the patient has already endured multiple failed surgeries?
A simple patch or a cartilage butterfly cannot bridge a near total defect. This requires lateral grafting.
And lateral grafting sounds like a massive escalation.
It is. The surgeon makes a post-auricular incision, a sweeping cut completely behind the ear to expose the underlying musculature.
Okay.
This wide exposure lets them harvest a substantial piece of true temporalis fascia, the robust connective tissue enveloping the jaw muscle.
And they take this tissue, strip away any fat, press it flat, and literally leave it to dry under an operating lamp.
Yes, to dehydrate it, it transforms from a slippery membrane into a stiff, highly manageable piece of biological parchment.
That's wild. Then they cut a very specific slit into the fascia at the 12 o'clock position.
That slit is an ingenious mechanical integration point. It allows the newly dehydrated fascia to slide seamlessly beneath the handle of the primary ear bone, the malleus.
So they mechanically couple the new drum to the existing acoustic chain, ensuring sound waves actually translate into vibration.
Precisely. But placing the graft is just the final step. Getting to that point requires serious bone work.
Yeah, this part sounded intense. They have to elevate the skin completely out of the ear canal and literally drill away the bone of the skull.
Using a high-speed drill.
Starting with a size 3 cutting burr and finishing with a size 2 diamond burr. Why does a soft tissue repair require aggressive bone drilling?
Visualization and optimal graft placement demand it. The anterior wall of the human ear canal often features a prominent bony overhang.
Okay, so it blocks the view.
Right. It obscures the front rim of the eardrum. If the surgeon fails to drill down that specific bony bulge, the lateral fascia graft cannot lay flat.
It just drapes over the bone instead.
Exactly. It adheres to the bony canal wall. This anatomical failure is known as blunting.
And blunting basically ruins the acoustic mechanics of the repair.
It does. The angle between the eardrum and the canal wall gets filled with thick scar tissue. A blunted eardrum lacks the necessary tension to vibrate.
Resulting in a permanent hearing loss.
A significant conductive hearing loss,
Yeah.
yes. The mechanical advantage is completely lost.
But blunting isn't even the most severe complication lurking here. The literature explicitly emphasizes the absolute necessity of removing all the skin cells.
Meticulous de-epithelialization.
Right. The surgeon must scrape every single microscopic skin cell off the remnants of the old eardrum before laying the new fascia down.
It is critical.
If they miss even a tiny speck of skin and trap it underneath the lateral graft, it sets a biological time bomb.
Yes, because squamous epithelium is continuously shedding and reproducing.
Normally that just migrates out as earwax, right?
Exactly. But if those dividing cells are trapped in the medial space beneath a tightly sealed fascia graft, the keratin debris has nowhere to go.
It just builds up. I keep thinking about it like laying down a beautiful, incredibly expensive new hardwood floor in your house, but you accidentally leave a live termite trap right underneath the floorboards before you seal it up.
That is terrifying, but perfectly accurate.
On the outside, the floor looks completely flawless, but underneath, disaster is quietly multiplying.
The resulting iatrogenic cholesteatoma operates on that exact destructive principle. As the trapped mass expands, it secretes enzymes that actively erode the bone and silently devour the delicate ossicles.
Wow. So after considering all of this, the high-speed drilling, the microscopic skin scraping, the risk to the taste nerve, how successful are these massive reconstructions?
Well, if we connect this to the bigger picture, the clinical data presents a highly reassuring consensus.
That's not that good news.
Whether the surgeon opts for a medial underlay, a lateral overlay, or a cartilage inlay technique, the literature consistently demonstrates closure rates exceeding 90%.
90%, that's incredible.
It is. And statistical analysis reveals negligible differences in long-term outcomes based purely on the grafting material utilized.
Wait, really? So it doesn't matter if it's fascia or cartilage?
The determining variable in a successful Tympanoplasty is not the specific biological patch. It is the rigorous surgical technique, optimal patient selection, and the precise execution by the operating surgeon.
It really all comes down to the hands guiding the instruments.
Absolutely.
We have covered an incredible journey through the microscopic geography of the human ear today. We've seen the sheer resilience of biological tissue.
We really have.
Exploring how surgeons reconstruct our acoustic interface with everything from cigarette paper patches to custom carved cartilage, all the way to heavy-duty dehydrated fascia placed with high-speed diamond drills.
It's medical artistry.
So what does this all mean? What should we take away from this exploration of medical ingenuity?
I think the most sobering perspective emerges when considering the section on alternative management.
Okay, what do they say? say?
The surgical literature is very clear about the functional limits of these procedures. A patient may present with a severe mixed hearing loss.
Mixed meaning two different problems.
Right. This indicates a dual pathology, a conductive loss caused by the physical hole, coupled with a sensorineural loss, meaning profound damage to the inner ear cochlea, or the auditory nerve itself.
Meaning the hardware of the middle ear is broken, but the software of the inner ear is also permanently corrupted.
Exactly. The surgeon could execute a mathematically perfect tympanoplasty. They could achieve a beautiful vibrating drum and fully restore the conductive pathway.
Yeah.
But the underlying sensorineural deficit remains untouched. The patient will definitively require a hearing aid post-operatively to manage the nerve loss.
Wow. So even with a perfect surgery, they still need a hearing aid. That puts the patient in a remarkably difficult position.
It presents a profound philosophical and medical dilemma. If you knew with absolute certainty that you would still require auditory amplification every single day, would you choose to undergo hours of general anesthesia, facial nerve proximity drilling, tissue harvesting, and the risk to your gustatory nerve?
That is a lot to weigh.
Is the pursuit of a structurally intact, quote-unquote, dry ear and the freedom to swim really worth that surgical gauntlet? Or is the braver, more pragmatic choice to decline the reconstruction, accept the alternative management, fit a hearing aid, and simply live with the anatomy you have?
Man, that is an incredibly heavy calculation. It definitely makes you realize how precious that tiny vibrating membrane really is.
It's something we completely take for granted.
Absolutely. So next time you reach for that cotton swab after a shower or step up to the edge of the diving board, maybe take a second to respect the microscopic engineering inside your head and just leave well enough alone.